Yeah, we can start.
Okay, thank you very much. Hello, everyone. I'm seeing Roland here. So happy to see you and everyone else. So it's a very short case today, very educative. Let's see. So, David, today what we have is this was a 16-year-old female who came to my clinic complaining of palpitations. Anything on that?
Okay, thank you, Joseph. So, anytime Joseph says this is a short case, I know it's going to be a difficult one. So, a 16 years old female presenting with palpitations, discussing palpitations, uh, you have a lot of differentials, and I think I do not have a well polished schema for approaching palpitations, but let's just say that someone who gets so palpitations, awareness of heartbeat, and so this awareness of heartbeat, maybe I think most of the time when we think of palpitations we think of tachycardia, and yeah, probably in the language of medicine that is what has been a synonym, but if someone reports awareness of heartbeat, it might as well be bradycardia, but because we are talking of palpitations, someone is aware of their heartbeat, a number of things can cause that. So you could think one of the things that you can think about is when there are issues with the electricity of the heart itself. So all sorts of arrhythmias, whether tachyarrhythmias or bradyarrhythmias. Uh, and when we talk of bradyarrhythmias, also include conduction abnormalities in there. So that's when there is an issue with the electricity of the heart, and this can be primarily a heart issue or secondary to something else like an electrolyte abnormality. So that's if the heart itself has issues. And then another thing, you could also think of tachycardia in terms of like tachycardia a little bit in relationship with syncope. That is, if someone has a problem with the pump itself, that is the heart. So, for example, a patient with heart failure, so some sorts of heart failure, someone might have tachycardia because of they are trying to compensate if the contractility is not very good, and then a problem with the pipes, uh, the blood vessels, particularly, or let's talk about the blood also in general, and which is another thing, a problem with the fluid in the vessel. So when someone is volume down, for example, they have massive diarrhea, vomiting, or acute blood loss. They have lost a lot of blood and the effective circulating volume is low. They will compensate by increasing the heart rate. Any reduction in oxygen carrying capacity, someone with anemia might present with tachycardia. And then you also have tachycardia, which is due to endocrine issues, pheochromocytoma, thyroid. So lots of differentials to think about. Therefore, when I hear tachycardia, I think the first thing is to know what are the accompanying symptoms in order to be able to narrow down. So, Joseph, back to you.
Yeah, thank you. That's so broad. Let's see the HPI. I'll read the HPI up until before physical exam, I think. So this child was essentially normal until 2 years ago when she started experiencing intermittent episodes of fluttering in the left side of the chest. And she would say that previously she had um, one or less episode per month, but they occurred at rest or during activity. And sometimes her heart would race up to the point she saw her left chest visibly beating up. But over the last 5 months, she said that she had three episodes which were different from the previous ones. So, in these three episodes, she felt dizzy and about to pass out, which necessitated her to stop and sit down. She said if she couldn't have done that, she would have fallen down. So she sit down and she squats. But she denied chest pain, shortness of breath, easy fatigue, lower limb swelling, anxiety, insomnia. She also plays sports normally in her school. Liver system, nothing abnormal. Past medical history, non-contributory. Family social history. She's in Form 4. She's in boarding school, so this was the time during holiday, so she came to hospital. She had a good school performance, as the parents told me, and her siblings and mother are in good health, but her father has hypertension. Yeah.
Okay, so a 16 years old female presenting palpitations for 2 years, which are on and off, so about one episode or less per month, and then over like 5 months, she reports 3 episodes, which are, and the issue is they do not have any specific aggravating or relieving factors, or so for example they can occur at rest or during activity. So if we talk of someone, for example, with anemia, we would expect the palpitations to be worse with activity and relieved by resting. So I believe these are the last 3 episodes. She feels dizzy, about to pass out. So which brings me to the point that if your heart is racing very fast, it does not have time to relax and allow blood to fill, and therefore even the cardiac output will be low. And when the cardiac output is low, the brain is not well perfused. Someone feels dizzy, and so this is it's a pre-syncope. So she experienced an episode, almost a pre-syncope. But we're told there is no chest pain. So, of course, even arrhythmias themselves, even if you are not talking of coronary artery disease, because with hypoperfusion, there can be hypoperfusion even to the myocardium, and therefore even arrhythmias. If it's a primary electrical issue, it can also come with chest pain, but she doesn't have chest pain, no shortness of breath. Uh, Broad, it doesn't rule out a lot, but at least shortness of breath, lower limb swelling. You think maybe it's not exactly, although it cannot be completely ruled out, but then you could say that maybe she's not in overt heart failure, because we would expect these symptoms, because for her age, you think that she's healthy. The past medical history is non-contributory, and therefore you think what exactly is going on with the patient. So in her age, if you think about cardiac abnormalities that could present, that could complicate with an arrhythmia, for example, think of valvular heart disease, and in our setting, primarily rheumatic heart disease. But then we, at least up to this point, we do not see anything that is in keeping with that. So the issue of anxiety, insomnia, I talked about hyperthyroidism. I talked about pheochromocytoma. So basically, anything that comes with a hyperadrenergic or sympathetic overdrive would come with these symptoms, which we do not see in this patient. Uh, the past medical history, I believe, a review of systems was unremarkable. Past medical history non-contributory. Uh, and then family social history also, nothing very much remarkable apart from a history of hypertension in the father, but other siblings, mother in good health, we do not see anything there. So up to this point, I think out of the many differentials that I talked about, we could rule out a few. We could rule out a few and say, so primarily what we are dealing with is an electrical issue in the heart. But then is it something primary? Primary meaning there is nothing else outside the heart that is causing that. Like I talked about earlier, electrolyte abnormalities or anything else, we do not see anything in keeping with those. Uh, at least up to this point, we are told she doesn't have easy fatigue, and these episodes come and go, which means all other times she is well. We are told she plays sports at school, and therefore it's unlikely to be anemia, for example. So anything that would cause persistent palpitations, unless the underlying cause is addressed, is not very likely here because of the intermittent nature. Then we think this is something electrical, maybe primarily in the heart, although something else could be triggering it. So those are my thoughts for now, but I think it's still not easy to commit up to this point, and I think maybe the most helpful piece, although again it may not be very helpful because these are intermittent, is when we come to investigations, especially an ECG. But maybe this would be a candidate for Holter monitoring. But let's see physical exam if there's anything that will help me make progress.
Thank you very much. Let's see the progress. So here is the physical exam. Generally, she was alert and oriented. She was not in distress. She was febrile. She was not pale. No jaundice, no lymphadenopathy, no lower limb edema. Blood pressure, pulse rate, respiratory rate, temperature, and saturation in room air were all normal. Exam, she had a regular CVS exam, a regular latent rhythm. She didn't have precordial heave or hyperactivity. She had a normal S1S2. It was no mama that was detected in auscultation. Other systemic exam like abdomen, respiratory system, neuro, musculoskeletal were all normal. So here are the labs that I did, and full blood picture, ferritin, RBG, renal function tests, liver function tests, electrolyte, thyroid function tests were all normal. Okay.
Okay, so as I suspected, physical examination is non-revealing in this patient. Because what we are dealing with is something that is intermittent, comes and goes. So general exam, unremarkable. Systemic exam, especially cardiovascular, regular rate and rhythm, no precordial heave or hyperactivity, no murmurs. So as I said earlier, uh, many times what we do basically is we are supposed to avoid premature closure, but then we almost always take shortcuts. So I see a 16 years old, she complains of palpitations. The thoughts that I talked about earlier, I would make sure I rule out anemia uh, and anything else that would cause her to be volume down. But if I localize the issue primarily to the heart, then I would definitely think, okay, this could be some sort of arrhythmia. What is the cause of this arrhythmia? But then, if it is secondary to structural heart disease, uh, in her age, I would think mostly about valvular heart disease. We're told there is no mom, although auscultation is not 100% sensitive, but our confidence goes down because there is nothing that is pointing in that direction. And the issue of a normal pulse examination, normal cardiovascular and other systems is not surprising because of the intermittent nature of this issue. And again, we come to the labs. I think the full blood picture is important. That means she doesn't have anemia. We are told it's normal. Uh, at this point, I think so. RBG, yeah, this is another important thing. So if someone has episodes of hypoglycemia, they do present with palpitations, and these can be intermittent. But then uh, hypoglycemia does not disappear without intervention. Someone has to take something for the hypoglycemia to improve, and therefore the symptoms to disappear. And so when you talk of Whipple's triad for definition of hypoglycemia, that is there. A normal RBG, of course, uh, it's difficult to think about hypoglycemia in this patient. RFT is not exactly related. Electrolytes important, especially potassium, but right from the history, we did not pick anything that was in keeping with an electrolyte abnormality. And then thyroid, very important in this patient because uh, hyperthyroidism could be a precipitant of the palpitations that she's having. So these labs are normal. So my next step would be a 12 lead ECG and see what's going on. And then if that also is non-revealing, I think Holter is important. But if you have anything else, let's see it.
Yeah. So let's proceed. Um, she did an echo, which was normal. Normal ejection fraction. No any abnormality was detected. And here is the EKG that you will tell us what you see. Yeah, I think this is the end of the case. So, yeah.
Okay, so I think I might need some help. I'm trying to zoom in and see what and see if I can pick anything. We touched something. Okay, so let me start with trying to find where lead two is. Okay, lead two is here. So I'll try and be very slow here because this is an after zooming in, the resolution is not very good on my side, but Joseph, if I miss anything, you'll help me. So I'll start with, I'll take baby steps here. So I'll start with lead two for anyone who is zooming in. Um, and the first thing I'm trying to see is if there is a P wave for every QRS complex. So the first one, I see a P wave there. The second one, I see it. The third one, fourth, fifth. Um, yeah, so I see, at least from this side, I see a P wave for every QRS complex. So the rhythm is sinus. So that was number one. And then number two, I'm trying to see if this is a regular rhythm. So because we have time, everyone bear with me. I'll interpret this ECG like the learner that I am. So I'm trying now to see if the rhythm is regular, and I cannot put a piece of paper on the screen, but quick looking, I see that it's let me see, for example, the first half, the RRI interval, it's like three big boxes and then plus, yeah, maybe one, which roughly translates to so it looks almost the same. I do not see I do not see irregularities in rhythm. So the rhythm is sinus, it's regular, and then the rate is approximately, so this rate I think could be a little less than 100. Uh, Let me see. So three large boxes. Yeah, so just a little less than 100. So approximately, I would say approximately 100. And so having seen that, then I'll go interval. I'll go now. I'll start checking at the intervals and segments. So I start with the PRI interval. And so this is when now I have issues because when I zoom in, it's difficult to see the small boxes. But I think the PRI interval, by approximating, I think this is one small box, two, three, maybe around four. So the PRI interval is normal. The patient has a normal PRI interval. And then the QRS complexes, now I think I'll have to check lead by lead. So when I check lead one, you see that the QRS complex, the upslope. So there is this, it's slanted and then it goes up. So I think there is a name for this. Is it epsilon wave or something? I think so. But you can see that, for example, when you look at there is a slight difference between lead two and lead one. So lead one, you see that there is it does not go straight up. It's there is some slope. I think probably the name is epsilon wave. I think Joseph will remind me later. So that's what I see at lead one, and then there's an overlap of AVR and AVL, but you see almost a sort of like an M pattern for an M pattern on AVL. But then if I try to check, because another important detail is to say this is wide complex or narrow complex. So I think uh, again, difficult to see the small boxes, but I think they do not exceed three small boxes. And therefore, if they do not exceed three small boxes, that is a narrow complex. Again, Joseph will correct me because it's hard to see them clearly. But then I see something like an M pattern. So there's an overlap you can see between AVR and AVL. But yeah, you see, so it goes up a little, down, and then up again. So it's like an RSR wave. So that is in AVL. Uh, take it down. I need to see the lateral leads V5, V6. So I'm at the QRS complex. I'm trying to see them by territory. So I started with lead one. I see, and antimony is telling me it's called a delta wave. Uh, so I've seen lead one. I've seen AVL. Joseph, I'm not able to see V5 and V6. I'm not sure if you've zoomed it in and slides have disappeared. Is Joseph still on the call? Hello,
Oh,
Joseph.
David.
Yes, your slides have disappeared.
Yeah, I got a problem with my internet. So let me project again. You said you want to see V5, V6, eh?
Yes, yeah, V5, V6 is here. So I see the same issue. I see the same issue. So this is what Antimon has told me. It's called a delta wave. That's V5, V6. So with respect to the with respect to the QRS complex, so I see the delta wave for, and that is in left-sided leads, and then for inferior leads, take it up again. I need to see lead 2, lead 3, and AVF. Okay, lead 2, lead 3, AVF. There again, you see that in lead 2, lead 3, it's almost like a W pattern. And AVF, okay, AVF unremarkable. Let me see V1, V2, and then V3, V4. Okay, so V1 again, it's like a W pattern. Oh, but then, of course, always the QR the QRS complex can be negative in V1, but you see the same pattern. It looks like a W pattern, but then in V2 it's opposite. You see like an RSR pattern, but V3 it's a proper W wave, and then V4 again you see the same. It looks a little different. It looks a little different from from that of AVL. So I think the main issues here with the QRS complex. So we've picked the delta wave. Let's proceed to the next segment. Take it up again. I need to see the QT interval. So first of all, I'll try to see the T wave deflection. With regards to the ST segments, I do not see any obvious abnormalities in the ST segments. But then the T wave is positive in lead 1, positive in lead 2, negative in lead 3, AVR almost negative, AVL it's positive, AVF it's negative. Take it up. V1 up to V6, Joseph. Okay, so yeah, this is something that is so the T wave is positive in V1. Now whether this is abnormal, because if you find a negative deflection in T wave, for example in lead 1, I do not really bother, but I see it's positive here, positive in V2, V3, and then with V6, I'm trying to see the T segment is a bit low, but I do not think if it's significant. It doesn't look like more than 2 millimeters. And then I think what I did not check is the QT interval. The QT interval. So can you take me to lead 2? Okay, not very well visible there, but for example, if I take lead 1, the QT interval, how many boxes there? 1, 2, 3. Okay, let's say 5. Okay, so a number of abnormalities that I've seen here. So the delta wave, especially on the left-sided leads, that is lead 1, AVL, I think it was the same also with V5, V6, but I also see it in some other leads. For example, even in lead 2, you see that there are no pathological Q waves. I should just okay, that's debatable, but I do not see any pathological Q waves at least. And then I also picked an M pattern at AVL. I do not remember if it was the same AW pattern, I think, for V1 and V2. I do not remember if any other of the left-sided leads, if they had that. But then this is a narrow complex. This is a narrow complex because from my side, it was not more than 120 milliseconds. So that's what I have. So this, and then are there any PVCs? For example, I do not see any PVCs because someone who presents with palpitations, some of the things that we see commonly are PVCs. So now my biggest job here, I think, is to connect these things. When you pick a delta wave and all these other abnormalities that I've seen, uh, what is the diagnosis? That is what I do not have here. So basically, what I would say is the abnormalities that we are seeing are what are predisposing this patient to the palpitations. I've read a number of conditions, uh, but so for example, when you talk there are what are called the pre-excitation syndromes. but pre-excitation syndromes, the common presentation is a short PRI interval. And then another is these abnormalities apart from pre-excitation syndromes, and I believe what we are seeing here, including the delta wave, could be part of what are called pre-excitation syndromes. Now I see here um, Nebo says wide QRS. I'm not sure if I could call this wide QRS because from my counting, the the QRS duration does not amount to 120. Does not amount to 120 milliseconds, and therefore I consider this to be narrow complex. But then Joseph will educate me better. Left bundle branch block. Maybe if we consider this to be left bundle branch block, we would say it's incomplete because the QRS complex from my side, I think it's a narrow complex, and therefore LBBB, we would expect it to be wide complex. Yeah, so another help that I get here is Wolff-Parkinson-White. So Wolff-Parkinson-White syndrome. Yeah, I think what I'm missing here is the connection. I could pick the abnormalities like a delta wave, but then connecting it now on top of the other abnormalities to connect it to a particular diagnosis. That is what I'm failing to do. So what I would say generally is this patient has a pre-excitation syndrome that is leading to the abnormalities that to the palpitations that she presents with. Whether this fits to be called Wolff-Parkinson-White syndrome, I think it's because of the gaps now in connecting. There is dissociation there between the abnormalities that I pick and remembering or recalling the ECG features of Wolff-Parkinson-White syndrome. So in general, I would say it's a pre-excitation syndrome. That is what is leading to these abnormalities. And then Joseph, I think back to you to reveal the diagnosis and teach me. I think I have a lot to learn today.
Yeah, that's a pretty good work from everyone and from you because it's different from what I did when I saw the patient. I didn't have a clue. So personally, when I saw the patient, I realized this ECG is not normal, but I didn't know now was there. And luckily, when you don't have anything, you share with colleagues. So I sent the ECG to a friend who is a cardiology fellow, and she's used to it, and she immediately say, "Oh, this is pre-excitation, as you're correctly saying. This is pre-excitation. It's a WPW. It's the same name." And so they say, "Okay." I looked at it again and say, "Yeah," and read, and they say, "Okay, the ECG pretty looks like it." And she also shared with the EP specialist in our hospital, who also said it's true. This is the WPW, and patient has to be brought for ablation. Yeah. So today's presentation was about just that ECG, and it shows that for me, if you're not used to seeing this, there is nothing like you know how to read ECG. Like for me, like I read ECG, but if there is an abnormality that you don't see on a frequent basis, you won't get it. We used to see WBW when we were in residency, and we would read for exams, but here it was, and I missed it. So yeah, a little bit of it. So what is this? The Wolff-Parkinson or pre-excitation syndrome. Uh, you all know the normal conduction, electricity conduction of the heart, which starts in the SA node and proceed to the AV node, and then to the bundle branches, Hicks, Purkinje, and on and on. But when you have the WPW, you have an accessory pathway, the green one, what you're seeing. So instead of electricity just going this way, it goes this and goes this. So pre-excitation, you don't have the delay at the AV nodes. So the ventricles beat normally. That's why you are seeing the normal QRS, but you have another beat, the upstroke you call the delta wave. The accessory pathway is also called a band of Kent. So the pattern, you have a short PRR. So it's unfortunate that I didn't show the whole EKG. The measurement, they also showed the PRR was 116, so it was short PRR. It's hard to measure it for yourself. And you can also have a wide QRS complex with a slide slow upstroke, which you call the delta wave. This ECG didn't have a wide QRS. The QRS was 119, slightly borderline, but truly that was a delta wave. So there's a difference between pattern and syndrome. A syndrome now, if you do ECG, like for me, I don't have symptoms, and you find those things, you say, I have a pattern. A syndrome is when you have that pattern plus symptoms. Like this patient had tachyarrhythmia, the episodic arrhythmia that she had, and they seem to be progressive because at the end they were starting to present with a pre-syncopal symptoms. And the arrhythmia, if you catch them, because we did the ECG when the patient was not symptomatic, she was there, the symptoms would like were not there. If we catch the arrhythmia, maybe we would have seen AVRT or AFib flutter, but some patient may just suddenly die, and postmortem shows that they had WPW syndrome. Presentation, most patients with this disease, they are asymptomatic. They just go on with their life unless someone catches the pattern on the ECG. But some patients will present with palpitations and this girl. Some will present with chest pain, syncope or pre-syncope, but others can present with just sudden cardiac death. And then others, as you said, you can like do an ECG for something else and you'll see the pattern. Yeah, so here's the ECG again to review it again. Very nice, Antimon and everyone, David. So for me, the one which shows clearly, I think is let me see this one, the AVL. Like there is this is a QRS complex, but it's pretty abnormal. Like this is not normal. Like it goes here, the pop up, and then goes again. So that's thing. The initial one is what they call the delta wave or um uh, uh, the slide upstroke called the delta wave. Pathognomonic for WPW. We see it, you say that is WPW. And so treatment, it depends how the patient presents. Like this patient came in asymptomatic, but if they come in with symptoms like they have tachycardia, pulse rate of 200, then you activate your flow for tachyarrhythmia. You say, are they like stable, unstable, and from there you go down. Not for this talk, but if they are not in acute tachyarrhythmia like in this patient, what you do is, as you have seen, there is a risk in the future for sudden cardiac death. So they have to be treated, as the EP specialist emphasized, that this patient has to be brought in because you prevent the arrhythmias to happen again and again. And treatment is that they do catheter ablation, which has better results than antiarrhythmic drugs. Antiarrhythmic drugs are for those people who can't have a catheter ablation. So we sent the patient. I haven't communicated with them, but I think there will be in a pipeline to do catheter ablation. And yeah, so that was their case today, David.
Thank you very much, Joseph. So, on my side, I would say I had a lot to learn today. So, short case and I believe everyone believes now when I say if Joseph tells you this is a short case, just know it's not going to be an easy one. Uh, so, thank you, Joseph. Lots of teaching from you, and this emphasizes what we talk about many times. medicine humbles you many times. So you can see that you pick the abnormalities on the ECG, but then putting a name, an ECG diagnosis was difficult for me, because yes, I've read about Wolff Parkinson White syndrome. I've heard about it, and so you see the findings, you pick the ECG findings, but then putting a name to that. So it's things that because we do not encounter these things on a daily basis, and therefore that's why we have platforms like this, because this is now crowdsourcing of knowledge and skills. So I believe after here, next time I see an ECG like this, it's unlikely for me to forget. So thank you very much, Joseph. I had a lot to learn, and thank you. I think that was Aniset for the help about of Parkinson White syndrome, and Antimon again reminding me about delta wave, and Neb also for the inputs. I see Hassan has a hand, so please welcome. While I saw a question. I'm not sure if it's a question or a comment from Ahmed. So after Hassan, maybe Ahmed, if you're in a position to unmute, you can also unmute and speak.
Hello, Dr. David. I have nothing to say.
I saw your hand up, so I thought you have something. Ahmed, you have a thing there. He says how to definitively differentiate between true pre-excitation and other causes of a wide QRS complex, such as bundle branch block. So if you're in a position where you can speak, please unmute and speak, so we can get clarity on whether this was a statement or a question.
Okay, Dr. Davy. That was a question because, as someone commented there, it was, I think, left band or branch block. So I didn't understand how can you differentiate between the true excitation and the others. Just a brief outline.
Oh, thank you very much for the question. So Nebo thought it's maybe Nebo, if you can share your thoughts on what made you consider that to be LBBB, and then I believe we have ECG specialists here, so they will teach us something. Nebo, are you there? Yeah, so while others, and if there is anyone who would also like to add something, you can just raise up your hand, and maybe after a few words, I'll welcome you. So with pre-excitation syndromes, the what I remember from textbooks, and my picture of pre-excitation is a PRI interval will be short. That's why even in this patient, although I saw that delta wave, I thought, due to I think I didn't have a lot of options, but then I had the thought of pre-excitation, but I also hesitated because my picture that I have of pre-excitation is the PRI interval is short. And what I've memorized about bundle branch block, for example, is number one, when you talk about complete, the QRS complex is wide. So the QRS complex will be more than 120 milliseconds. So that is more than 3 small boxes. And then on top of that, you have abnormalities of the QRS complexes, so they will not be going straight up or straight down. For example, if you're talking of left bundle branch block in the left-sided leads, in addition to them being wide QRS, you'll also see an M pattern, for example. So it's like you are drawing an M it's an RSR pattern. So goes up and then comes down but goes up again. So you see it's almost like an M. And then on top of that, you will see, you can see a W pattern, especially on right-sided leads, V1, V2 probably. You see a W pattern that is for left bundle branch block. And then you also have absence. For example, in left bundle branch block, you can have complete absence of a Q wave. That is, for example, for left-sided leads, you have absence of a Q wave on the left-sided leads. So you have that M pattern. So wide QRS complex, and then the pattern that you see, whether M pattern for left side for LBBB, M pattern you'll see in the left-sided leads, and then W pattern on the right-sided leads. So those are the few ones that I can recall off the bat. So for pre-excitation, short PRI interval, and then the other abnormalities like the delta wave that we saw, and for bundle branch block, wide QRS complex, and then those other abnormalities. So if there is anyone else with anything to add, I think that will cement our memory and make sure we do not miss these next time. Okay, I do not see any hand, but then if yes, so this is another thing. Nebo, I'm not sure if you're in a position where, okay, Nebo says he's on transit, and yes, that is another thing. You have a dominant S wave on V1, and then V6 broad notch data wave. Those are some features of LBBB. So that is what will give the M pattern and the W pattern. So M pattern on V6, W pattern on V1. Yes, Ahmed, please welcome.
Thank you, Dr. David. I think I got the essence of the EKG. But I had another question.
Yes.
Say the patient was asymptomatic, and on the EKG we find the delta wave. Just maybe from risk stratifying, you decide to do the ECG, and you find that she has a delta waves, but she was asymptomatic. No, the history of palpitations, no, the tachyarrhythmias or abnormalities in the pulse. So how are we going to reach to the same conclusion of WPW?
Yeah, so I think that's what Joseph told us, that with symptoms, we'll call that Wolff-Parkinson-White syndrome. But then without symptoms, if the patient is has those abnormalities, but without symptoms, that would be the WPW pattern. Now, Joseph, in your reading, if someone also has a Wolff-Parkinson-White pattern, is treatment also warranted? Or
Yes.
okay, so
Should be treated.
Okay, so treatment is for both the WPW pattern as well as syndrome.
Yeah, to prevent future arrhythmias and sudden death.
Okay. Okay. Thank you very much. Is there anything else from anyone? We still have like 5 minutes. If anyone has anything before we close, please welcome. Yeah, I do not see any hand. Joseph, anything before we close?
Nothing.
Okay, so thank you very much, everyone, for joining. I hope I personally had a good time, because I learned some new things, and I hope you had a good time too. So again, we remind people that we need discussants, we need presenters. So if you have a case, which I believe you do, you see some interesting cases that we can learn something from, even if it's one piece of information that we can learn, that will improve our practice. So for example, today our learning was on the ECG. So if you have those cases, please bring them and present so that we get an opportunity to learn. And then we also are in desperate need for discussants. We need new wisdom. So if you feel like you need to discuss one day, just at the beginning or even before starting here, you can reach out, because I believe most of you are in the groups. So you can reach out to me or Joseph and express your interest to discuss, and you can discuss, and it will be a very good opportunity for us to learn from you. Otherwise, thank you very much everyone for joining, and have a good night. See you next weekend.